Good morning. Good afternoon, everyone. Welcome, ladies and gentlemen, on behalf of the Board of Governors of the Asia Pacific Sathya Institute for Human Values Education. It is my great pleasure to welcome all of you to the Step Forward to Age, Aging Gracefully and Effectively. We are delighted that you have taken the time to join us today from across Asia Pacific region and beyond. I would like now to extend our sincere appreciation from the Institute to our distinguished panel of speakers, experts from Malaysia, Singapore, and the United States who have graciously accepted our invitation to share their expertise and their insights. We are truly honored by your presence. Today, the Asia Pacific Sathya Institute for Human Values Education is a regional center dedicated to advancing human values education across Asia Pacific. Working in collaboration with the Sri Sathya Sai International Organization, SSIO, the Institute promotes education that develops not only knowledge and skills, but also character, compassion, and responsible citizenship. Our programs span children, youth, educators, families, leaders, and communities because we truly believe that learning and personal growth continue throughout every stage of life, which brings us today to our webinar reflecting that philosophy. Population aging is one of the defining demographic changes of our time. Longer life expectancy is certainly something to celebrate. Yet, the more important question is not simply how long we live, but how we live. Aging gracefully and effectively is about much more than preventing disease. It's about maintaining our physical health, preserving our mental well-being, remaining socially connected, living with purpose, and continuing to contribute meaningfully to our families and, of course, our communities. This webinar today is the first in a planned series that seeks to bring together leading experts globally to explore aging from a holistic perspective. Today, we hope to raise awareness of these key issues. Thank you once again for joining us. On behalf of the Institute, I would like to warmly welcome all of you. And it's now with my great pleasure to hand over to our moderator, Dr. Kajal, who will guide us through this afternoon's program. Over to you, Dr. Kajal. Thank you.
Thank you very much, Prof. Ganesh. So before we begin, just some housekeeping rule. If you could please request that your microphones are on mute so it doesn't interrupt the flow of the webinar. Thank you, and we hope you enjoy the webinar. So now let's officially start. A very warm welcome and good morning to colleagues who are on the other part of the world. Good afternoon, good evening, and thank you for joining us for this Step Forward to A.G.E, which is Aging Gracefully and Effectively. I'm Dr. Kajal, and I'm the privilege of having to moderate the session today. Now, aging is something that touches every one of us. Some of us are aging ourselves. Some of us are caring for aging patients. Some of us are watching our loved ones change, be it physically, emotionally, mentally, or even socially. And many of us are wondering, how do we do this better? With more dignity, with more confidence, and some support in the community. So today's session is not meant to be a formal lecture. There are already many lectures out there in the social media, and information resources are already widely available on aging. Instead, we want to use this platform to discuss real-life scenarios and deep dive into the core issues that families and we often face. A fall is not just a fall. Poor sleep is just not a matter of sleep. Eating less is not just about appetite. And this continues. But often, when we just listen to facts, we realize we're not able to absorb it as much. But when the message is linked to stories that we can relate and connect, it now becomes even more easy to understand and remember. So today, we hope to have a very practical, honest, and meaningful conversation guided by experts in terms of their insights, but grounded in real life that we face in our day-to-day. Now, before we begin, I would like to invite everyone to take part in a simple reflection. In the chat box, please type one word that comes to your mind when you hear the phrase aging gracefully. So if I can welcome each of you to type, what was the first thing that comes in your mind when I say aging gracefully, or when you hear the term aging gracefully? You can just type in the chat box. So I'm loving this, that we are really starting this on a positive note. As you can see, everyone who has typed in, aging is not just about numbers. It's about happiness. It's about peace. It's about freedom. It's about being independent. And many have also put mobility, because you want to be independent only when you can be mobile. Good health, healthy aging, at ease with oneself. Majority is still talking about togetherness, being wise, content. So as you can see, it means so different for different people, right? Right from physical ability to emotional well-being and even mental well-being. And keep this going. It's really nice to see what we all feel about aging gracefully. And that itself is a witness to why all of us are gathered here on a Saturday afternoon. Now, these are beautiful responses. And that is exactly why we are here today. So today we're going to be discussing through 3 real life scenarios. They're not rare cases. They are not out of blue AI generated cases. These are cases that we see in our day-to-day practices and we see in our own homes, clinics, and our community. We'll talk about falls, fractures, memory, confusion, insomnia, which is troubles with sleep, and caregiver stress, and how the community can be a huge part of this and not having to suffer this in silo. To help us unpack all of this, we have been honored to have a multidisciplinary expert panel with us. We have Prof. Joseph Nicholas, a professor of medicine at the University of Rochester, and William and Sheila Connell, family professor in geriatrics, palliative medicine, and person-centered care. He also serves in senior educational and clinical leadership roles in Highland Hospital, including Associate Chief of Medicine, Director of Medical Education, and his academic research are mainly in clinical reasoning, decision-making, geriatric co-management, and medical education. This makes him especially well-placed to guide our discussion today. Welcome, Prof. Joseph. Next, we have with us Dr. Hitendra, specialist orthopedic and trauma surgeon based in Singapore with subspecialty expertise in complex fractures, joint replacement and reconstruction, and geriatric orthopedics. He previously served as a consultant orthopedic surgeon in Tan Tock Seng Hospital and was instrumental in establishing Singapore's first ever hip fracture care pathway. Next, we have Dr. Surina, an amazing colleague of mine who we work together in University Malaya Medical Center, a geriatric psychiatrist in UM with over 2 decades of clinical experience and extensive research. Her expertise focuses not only in dementia, but it's also with its associated behavior disorders and geriatric mental health. And finally, we have the ever-inspiring, the icon of healthy aging herself, Madam Lily Fu, a gerontologist, educator, writer, social advocate dedicated to promoting active and healthy aging. She's also the founder of Seniors Aloud, Malaysia's earliest online community, also the vice president of University of Third Age. It's a U3A. It's something that we would delve in a little bit more so that we understand a bit more on what the roles are. Each of them brings in a very different lens because aging well cannot be solved by just one person or one profession alone. It needs to be medical care, emotional care, rehab, family understanding, and community connection. So let's begin. So before we move on to the panel discussion, I would also like to welcome you all to join our WhatsApp community group. This group will help us share updates on future webinars, aging-related modules, useful resources, and even the upcoming sessions that follows this pilot Age webinar series. Now let us begin with our first scenario. So this is the story of Madam Lim, a 78-year-old widow who was previously independent. She could go to the market, attend her temple activities, and help around the house. Though the family did report that she had some short-term memory loss, they needed to prompt her on her day-to-day activities, but she remained independent. One day, she slipped and fell in the bathroom. She sustained a hip fracture. She had surgery done, and while she was in the hospital, she was completely not herself. She was agitated, she was pulling out the lines, she was trying to get off the bed, and she was literally harming herself by not wanting to eat. And after the surgery, as she was planned for home, she became very afraid to walk. Her family, out of love, began to do everything for her because they were worried she might fall again. Within 2 months, she became weaker, lost weight, stopped going out, and refused. Oh, sorry, technical. So for those of us who are in Malaysia, we do know even our past Prime Minister, Tun Mahathir, at the age of 101, actually just recently had a hip fracture. So hip fractures in older persons can be very debilitating. So before we start, as you can see in your screen, there is a poll question, in this case of Madam Lim. After an older person has a fall or a fracture, what is the most important thing to do? You have got 4 options that you can choose from. Let them rest and recover, reduce walking so they don't have another fall, treat the fracture if needed and help them walk again as soon as possible, or have a caregiver to do most activities for them because they need to rest, otherwise they might fall again. So we can see the results on our screens. Majority of us has chosen treat the fracture if needed and help them walk again as soon as possible. This said, it's easier said than done because we are always worried that they might fall again and what's going to happen when they fall again. So we can probably stop the poll. And now just deep dive straight to our experts. So Prof. Joseph, from a
Good morning.
geriatrician's point of view, what happens to the body when an older person stays mostly in bed or in chair after a fall?
It's really quite dramatic how negatively that impacts the older adult. I think when we're younger, we think when we're sick or hurt, it's good to rest and stay in bed. But this is the opposite as we get older for sure, mostly because as we get older, we lose so much muscle so quickly just from immobility. There's been studies that show that even with 1 or 2 weeks of being in the bed or not walking as much as usual, we can lose up to a quarter of the muscle that we have in our body. And that amount of loss is sort of the same as we lose naturally over maybe 10 years of life at this point. So sometimes when my patients leave the hospital after a hip fracture, or if they've been spending a lot of time in bed, they've almost lost 10 years of strength. And they are much older when they leave the hospital. So mobility becomes a really important priority, and maintaining muscle mass is very essential for the older adult.
So following that, Prof. Joseph, so what can we do to keep our bone and muscle health better as we are aging?
It's I think, as you said, easier said than done is a nice way, but we need to adjust our goals and not let people stay in bed. So the most important thing I think is to have people have routine daily activity. And this can be strength-based activity where walking for the lower body, upper extremity exercises for the upper body, and these need to happen consistently and daily. Now, most older adults are fearful, or their families are fearful that they might fall. And so we do everything possible to make this safe with things like good footwear, maybe a walking or assistive device like a cane or a walking frame, and involving them in daily activities where they're continuing to participate in family life, maybe with a little bit more supervision or help. But certainly we want to encourage them to move as much as possible so that they don't lose the muscle mass even after the bone is healed and not be able to walk again.
Right. So what I gather is basically movement is the key and safe mobility, whether it's with assistance or even getting your bone health ready as you're healing from the fracture. Okay.
Absolutely.
Now, Dr. Hitindra, can I just ask you, based on Madam Lim's case, this is a 78 years old lady having to go through surgery. Are surgery okay for older person to go through? Are they not at high risk? Should I worry as a family member?
Right. So I think it's a very common concern that many family members would have because with an aging parent and needing to undergo a surgery. But you have to be assured that many fractures, the best way to treat is through a surgical uh, means. For example, if someone has broken the hip, and hip fractures are on the rise globally. Now, with a hip fracture, you are basically losing all mobility, which means that you're going to be bedbound. And by being bedbound, you're actually inviting a lot of other complications, such as getting bed sores, urine infection, chest infection. You'll also lose, enthusiasm in living. You'll feel more depressed. And basically, it's a decline all the way. But if you do a surgery and you get a hip replaced, immediately after the surgery, the patients are made to stand and walk, and with good rehabilitative support, patients are back to their active lifestyle. So the only concern here is whether the elderly is safe to go for a surgery. So in the past, many family members and individuals had a lot of concern. But with current day, advancements in anesthetic techniques and a disciplinary approach where, we collectively look at the patient and we do a risk stratification. Most of the time, patients can happily and safely go through a surgery. And concerns of surgical risk should be minimized because the benefits of surgery outweigh the risk. So that is the main key here, that everyone should realize that most of the time, the benefits of a surgery would outweigh the risk. And with that, understanding, uh, patients can actually go through surgery very well without significant complications. And the goal here is to restore the quality of life. So that's something very important.
So Dr. Hitindra, is really not the age, right, that limits them from doing the surgery, because I think the belief is that, oh, you're already 80 or you're 90 and it's going to be a high risk surgery, so I better not, because at this age going through a surgery, no point. So is that right to say that it's really not the age to decide whether or not you are fit for surgery?
Exactly. Age is not a concern because it's more of, their pre-existing condition as a whole. And if they are truly not fit for surgery, the anesthetist will say so. But if they are fit for surgery, most of the time, the anesthetist has no reservation. It's just that it's a common belief in the public's eye that, this may happen, that may happen. But we always have a reassurance when an anesthetist sees the patient and gives you a green light, meaning that from the cardiac perspective, from your medical perspective, the body can actually undergo anesthesia safely and you can actually recover very well, irrespective of your age, whether you're 60 or 90. It does not matter.
Okay, and Dr. Hitendra, what do you think it's really the problem here? Because often after a surgery, because we're very caring as family, they go back home and we are almost always limiting them. Okay, mom, don't walk, don't get up. You just came up from a surgery. So what do you think is the mistake here? How should we now, see these patients post-operatively when they come back home to us?
Right. So basically, you should always encourage early mobilization, and mobility. But what I would like to say is after a surgery, there is a new norm because the person may have fallen down because of, trying to climb on a stool to reach for something on a high level cupboard in the home. But the point is, we should avoid such activities because this is the main preventive aspect that we should all understand. Another example is sometimes, people, elderly folks get up in the night to go to the washroom, but they just suddenly get up, and because of hypotensive situations, they suddenly lose consciousness and they fall down, and that's how they have a fracture. Another example is, sometimes elderly folks go to crowded places on rainy days and the floors are very slippery, and that's how we end up falling. So it's not about being active. It's not about, not being involved in social activities, but there should be a new norm, meaning that you should participate and be active, but with extra care, extra precaution. Always wear, the preventive spectacles, I would say, so that you are always mindful of how to avoid falls. That is the key. It's not about not allowing them to walk or be active, but it is to teach them and to help them understand the importance of prevention. And we as a family, we can do a lot of things to manifest this environment, whether it's at home or outside in society, to manifest this situation where it's safe and you can prevent a lot of unwanted falls.
Right. Okay. So, thank you, Dr. Hitendra. I'm now going to swing over to Dr. Surina. Madam Lim here says that, she now feels like a burden after the op, and she's refusing physiotherapy. Dr. Hitendra and Prof. Joseph nicely illustrated the need of engaging them on physiotherapy and safe mobility. Now, how do we distinguish fear of falling from depression? Because for someone who was so independent and suddenly not being able to walk independently can be quite emotionally debilitating.
Yeah, this is very important questions, and I suppose that fear of falling and depression is always overlapping. However, it's very important for us to differentiate between which one is fear of falling, which one is depression, because it can determine the managements here. But as for a start, we can see that people with the fear of falling, the main concern here, they're afraid of I might fall again. However, if someone that having the depressions, their focus is not about afraid of falling. They always think that I'm the burden of the family. I'm not useful for the family. My life is no meaning. So it's more on the cognitive distortion rather than the fear of falling. And usually for someone that having fear of falling, their trigger is related to event, meaning that fall. When we ask them to walk, they're afraid of fall. However, in people with depression, they may not have any trigger. They just don't want to do things, and then they feel that okay, I'm the burden of the family. I don't want to do anything, and in the fear of falling, they try to avoid any activity that may predispose them to fall. However, it's only related to the fall and walking. However, in people with depression, they avoid everything. Even not involved with the walking, they still refuse to do things. So we can see that from some things that very focused on walking, for someone that depressed, they refuse to do everything that involve their daily activities. And in the someone that fear of falling, they always worried and anxious related to fall. The focus here, fall. However, in depressive people, their loss of interest, the persistently low mood, hopeless, related to everything. And end of the day, their perceptions is I'm the burden of the family, so I don't want to do anything. So it becomes very persistent and involved with other associated symptoms with the depression. So as easy for us to remember here, fear falling focus on fear of getting hurt again due to the walk. However, in the focus of the depression, feeling like a burden. So they always avoid walking for the people with the anxiety, the fear of falling. However, in the depressions, they avoid every other activity. Apart from even it's not involved with walking, they refuse to do things, and it's always associated with the other symptom of depression. For example, low mood, poor appetite, and low motivation. So this is something that we can differentiate. So we can see that fear of falling is only related to the fall and it's not persistent. In contrast with people with depression, the symptom is not only focused on the fall, it involves everything in their activity, and it's a bit and it's also persistent and supported with other symptom of the depressions. So this is how we differentiate these two.
Right. Okay. And I guess when an older person gets depressed, they hardly talk about it. At least in our culture, we don't talk about, our mental health as much. And we as family will have to look at all these subtle signs, refusing to eat, refusing to go out, as signs to see that, oh, maybe my family or my loved one is depressed. Now, Madam Lily, Madam Lim's case has shown that recovery is not just medical. It's really a lot about what the family and community can do. To support the recovery of someone who is healing from a fracture. Would you be able to advise what community support is there for families and for patients to be back into the community, to support them to recover and get back to what they could do previously? Like Madam Lim used to attend temple activities, go to the market. What have you got to say?
Okay, before I get to answering your question, maybe I could just go back a little bit. Since you're talking about real life cases, let me give you a real life cases. My mother, okay, back in 2011, she fell. At that time, she was 85. She fell, and I didn't know because I was away attending a conference in Johor Bahru. She was alone at home. So when I got back one day earlier, luckily, as soon as I got into the house, I saw her lying on the floor outside the bathroom. So immediately I asked her, Mom, what are you doing on the floor? I mean, quite a silly question to ask, but I asked her that. And her answer surprised me or shocked me really. She said, on the floor? Am I on the floor? So this was a clue that, something must have happened when she fell. Either she knocked her head on the floor when she fell, or it is the early sign of, much more serious problem than that. So anyway, to cut a long story short, she was hospitalized, had surgery on her hip, was fractured. So she had surgery there at the age of 85 in the year 2011. In those days, I have to admit, I didn't know very much about dementia, Alzheimer's especially. So we just all reading up, Googling. Wasn't that good also to Google at that time? But yeah, I want to emphasize that she went through a period, I think about almost a month of rehabilitation at the hospital. Every week I will accompany her because she was staying with me, just the two of us in the house. So we did all the physiotherapy exercises recommended by the nurse. And after about 2 months, she slowly got her strength back. And she was able to walk, 85 years old, 85 years old. She was able to walk around with a walking stick and so forth. So which is okay. But unfortunately, about 2-3 years later, she fell again. So when you have a first fall, there's always a higher chance of an elderly person falling again, right? So this time a bit more serious in the sense that she first was a hip fracture, second time was a femur on the other side, also required surgery. By that time, her Alzheimer had worsened. So it was not easy in the hospital. She had to be put under restraint, which was very difficult for, the family members to see her being tied up, the feet and then the hands. So, all 4 limbs were tied up. The reason being, she couldn't remember that she just had surgery. And all the time she wanted to go to the bathroom. Even though we all told her that she has got diapers on, it's okay, it's okay. She just couldn't register it. So she was yelling and screaming and cursing me, everything. But, just want to share with you, it's not easy. So this time, after the second fall, even though we went through the same rehabilitation exercises, she lost a lot of interest in wanting to do it, to do them. So when we took her back home, we got a home visit by a physio. Of course, you have to pay the fee. And after, unsuccessfully trying to coax her to do the exercises, even the physio himself gave up. He said, there's no point. You're paying me for nothing. I come here, she refuses to do what I tell her to do. So in the end, we stop it, and she refuses to even get up to walk because she was so scared of falling again and having to go to a third surgery. So she never walked again. And that's what I want to say, right? Physiotherapy can help you to a certain extent, depending on your age. But when you have 2 falls, it really affects your, ability to want to try again. You kind of like give up because of the pain. So
I guess, so Madam Lily, I guess that's where preventive comes in. So we hope that, we can prevent them from falling falling ever. And if they've already had a 1 fall, hopefully with more cautionary measures at home in terms of home safety,
right.
keeping the home and the environment safe, we can prevent them from getting another fall. But just one last, back to the question that I asked you, how do you now integrate people back into the community? Are there some support systems there that can help them?
Yes, I was about to go to that. Yeah. So with my mother, the last few years I had to put her in a nursing care home because I couldn't manage, right? So over there, you have to choose a nursing home. You got to go more or less like shopping for a good one, where you have all the activities in place and everything. But to anyone who's going through such a similar situation, being in a wheelchair doesn't mean that you're totally cut off. It all depends on whether there are opportunities out there for social engagement, a lot. Yeah. For example, in U3A, University of the Third Age, also in our seniors allowed community, but it all depends on the individual. And for us in aged care, we really want to encourage them to think positively, that there is life out there even after a fall, even if you can't walk again. Mingle, get to know people. There are always friends around who will support you, family members and friends as well. And I would like to talk a bit more later about bringing the kampong spirit back to the neighborhood. Okay?
Sure. Thank you,
you.
Madam Lily. So if I understand, basically, even if someone has had a fall and if they are a bit more slow, I think we shouldn't confine them just to home. We have got to try to bring them back to the routine that they used to. Even if it's a bit more slower, needing more assistance, it's okay, but they need to get back to the routine so that they can regain the confidence that they have and they know that they can be pretty much close to what they were before this. Social participation is something that I think we don't talk enough for our older persons. Thank you so much, my dear panelists. So we're just now going to move on to the second scenario. If I can just get the slide to be so that we can, sometimes seeing a picture can give us a better understanding. So we're going to be talking about Mrs. Salama. So she's a 79-year-old woman living with her daughter's family. She has diabetes, high blood pressure, knee pain, mild hearing impairment, and early memory concerns. Since her husband passed away, she has become less active. Most days she just sits on the sofa, watching TV, naps several times during the day. At night, she cannot sleep. She lies awake and gets up several times to pass urine and only sleeps properly near dawn. By morning, she's really drowsy, groggy, and irritable. Over the past few months, she has been seeing different doctors and has received several different medications, whether it's sleeping tablet, a flu tablet that a lot of GPs like to give to make someone drowsy, painkillers, cough syrup, and also some herbal calming tea to help him sleep better. One morning, she wakes up groggy, rushes to the toilet, feels dizzy, and yet again has another fall. Now, sleep, nocturia, reverse sleep pattern is not something uncommon to all of us. We often see older persons grappling with this issue of sleep. And the question really is not about what other medications can I give her, is how can I help her sleep better? So now we can just launch the poll and just to understand a little bit better. So sleep is essential in an older person, but when one cannot sleep well, what is the best next first step? Recover sleep deprivation during the day, like how Mrs. Salama did. It's normal for older person to not sleep well. Ask for a stronger sleep tablet if the flu medication does not work enough, or review her daytime routine, pain, urination, and mood. Okay, so it's about 70% of us in the audience who are saying that we should review daytime routine, their pain, their urination, and mood. We also have some of us who say that we don't try to recover the sleep deprivation during the day instead, or it's normal for an older person to not sleep so well at night. So, Prof. Joseph, now sleep troubles and older person goes almost hand in hand in every of our clinical consult that we see these patients.
Kejal,
Yes?
one
Yes?
second. Sorry to interrupt you. Just to let everyone know, there is a closed caption. Should anyone want to read so that they can capture what's being spoken? If you look at the bottom of your screen, you will see a closed caption. Just press that, and you can see the text of everything that is being spoken or discussed in the live Zoom at the moment. Thank you. Over to you, Kejal.
Thank you, Prof. Ganesh. So, Prof. Joseph, as I was saying, it's a common scenario we see in our day-to-day clinic practices. What is the first thing when someone tells us that they can't sleep well? How do you approach these older people?
Yeah, and you're right, Dr. Kajal. I think there are some things that just happen naturally in our bodies as we get older. As we get older, we sleep less, and we often sleep less in one stretch. And this idea that we will go to bed at night and wake up feeling refreshed every single morning is a little bit starting to change over time. It is interesting to know that for most of us, our bodies begin to wind down and prepare for sleep earlier than when we're in our middle life. And so it's very common for, as people get older, for the circadian rhythm in the brain to start to set up the body for sleep 1 or 2 hours earlier than when we're older. And sometimes that can conflict with the family routine. I think one of the big lessons we've learned in geriatrics is that you need to work with the body as it's aging and not force it to do other things. And so these earlier bedtimes end up being sort of important. The second thing that I think gets difficult is nighttime is a time where if you're waking up frequently overnight and getting up to use the washroom, for instance, it can be a more risky situation. And so trying to create an environment where that's less likely to happen by adjusting maybe what you eat and drink in the few hours before bedtime to do this as well. And lastly, I think there is a hope. I think when we are younger, we imagine that if we take a pill, it will help us go to sleep. This becomes very dangerous in older adults where there is no medicine that doesn't cause another problem. And so the use of things that would make sense to a younger person, like taking a sleeping pill, drinking something that might make you sleepy. Those often produce side effects that are even worse than the not sleeping. And so we end up having to work with creating the environment and creating the expectation that our sleep will start earlier, it will be shorter, and we will need to create a safe environment for those times when we do wake up so that we're not at a risk for a fall or injuring ourselves.
Okay, so if I understand correctly, it's basically creating a routine in the evenings so that we avoid diuretics, maybe like coffee, tea, beverages, so that we don't feel like we get up many times at night to pee more, and also creating a more calmer environment, but avoiding all these drugs at all costs if possible.
I think that's true. And I guess the last thing I would say is one of the things that makes it hard to enter the sleep, for the brain to enter the sleep phase, is too much stimulation. As we get older, it gets harder and harder to block out extra stimulation. And so even in our world today, where there's a lot of digital information coming at us at all time, particularly in the evening through the TV, through the iPad, through the computer, these things can really disrupt the ability to enter a normal sleep, or as normal sleep cycle as possible. So I think, Dr. Kejal, like you suggested, this routine becomes important. And one part of the routine is to begin to slow down the stimulation, maybe 1 hour before bedtime, where people are maybe reading or maybe listening to music instead of sort of participating in a highly stimulating environment with lots of lights and sounds and different conversations sort of going on at once. So I think you've got it right. I think this routine becomes important because the human brain needs to relax a little bit earlier in the night as we get older to promote sleep.
Right. Thank you, Prof. Dr. Surina, I saw you vigorously nodding your head when Prof. Joseph said that, yes, the medications causes more harm, but because a lot of these drugs are over the counter, or, when we pressure the practitioners to, give us something to help us sleep, people eventually just get these medications. So would you be able to advise us some of the adverse effects? And can you also tell us how does sleep get affected in someone who is, say, anxious, someone who has got dementia with maybe some behavior disorders, and someone with someone with depression? Because Madam Lily highlighted a case of a mom just now who was, just trying to get off of the bed, wanting to go and urinate, although she was already on diapers. Would you be able to shed some light?
All right, thank you, Dr. Kijal, because this is topic that I am very interested on this topic, because majority of my elderly patients come to me because of this complaint. Because they come to you, doctor, my sleep's not good. Can I have a good sleep like when I was younger? And they request so many pills. Sometimes they already come to you with pills that they bought outside. But somehow this is the thing the thing that Dr. Joseph highlighted just now. The activity during that time make them relax is very useful, because in elderly, when they have a sleep issue, the first thing we need to rule out the other medical problem and polypharmacy that leads to the sleep problem. Okay, and after we rule out all the possible causes, the next thing we should think of depression in elderly. Like Dr. Keja mentioned just now, during our first case, depression is a little bit tricky to be diagnosed, because they not come to you with the complaint, I feel sad, I have low mood, I'm not happy with things. Unfortunately, elderly, they come to you with, I cannot sleep. My sleep is not good as before. I cannot rest my mind. So many things in my head, but I cannot point it out what is actually my problem. So this is usually the common presentations in elderly. After we rule out other medical causes, medication causes, then we need to bear in mind possibility that they have either anxiety and also depression. Because in depression in the elderly, they always have problem early morning awakening, or sometimes they're having difficulty to maintain the sleep. They just wake up in the middle of the night, they cannot sleep back. So this is common in depressions, inability to maintain the sleep. However, in anxiety people, because they always have a lot of things in their mind, they think a lot. They cannot shut down their thoughts. So they have a lot of things, racing thought, that make them unable to relax, and they're unable to initiate the sleep. So this is the two different things. People with depression, sometimes they're able to sleep, but they cannot maintain the sleep. However, in anxiety, they're having difficulty to initiate the sleep because their mind cannot relax. However, in grief, some people, they have grief also quite common in elderly, because when they're having grief, the sleep is very patchy because they don't have many activity because of the loneliness. They have frequent nap. during daytime. So definitely, if we have too frequent nap in the daytime, of course, the sleep would be affected at the night. And another things that Dr. Keja highlighted about the sleeping medications, right? So this is another big issue, I think, is for us here, because sometimes they manage to get the medication over the counter. But the problem is, it's not like we against the medication, sleeping medication for them, but somehow these medications most of the time will cause confusion. Sometimes they do have problem, because just now I see one of the question, they're having BPH, right? So they need to wake up middle of the night for urination. And then we add the sleeping medication, it make things worse, because they need to wake up because of need to pass urine. However, they're on sleeping pill that causing confusions and lead to the fall. So this is the thing that very dangerous for us. Because some of my patients would say that, okay, I do understand that sleeping medication can cause dependence and tolerance, but just give me, doctor, I only live another few years more. They would say that to me, But my focus is, I always tell them, I'm not worried about dependent and tolerant at this age. My concern is usually about fall. Now you can be very independent. You can go anywhere, like whenever you like it. But if you have confusion, you fall. And I'm afraid that you become dependent to people. So this is my focus on why we worry on sleeping pill for elderly. Risk of fall is higher. And also at the same time, they can, at the long term of when they take the sleeping medication, it definitely can affect their cognitive functions. We do have some of our patients that are on long-term benzodiazepine, unable to stop, and eventually when we see that the cognitive functions start affected. So this is another concerns that why we try to limit our usage of sleeping pill in our elderly. Okay?
Thank you, Dr. Serena. Madam Lily, I mean, this case isn't very different from a bit what we were trying to illustrate about mom earlier. So can I just ask, in Mrs. Salama's case, she started, becoming a bit more isolated, withdrawn, because after she lost her husband and had troubles in sleeping. So loneliness, social isolation it's really something that older people do face very regularly. How do you advise, or how do you suggest older people to, I mean, they are grieving, not denying that, but how do they now get back into the community? Are there certain resources out there that can help them beyond just the family alone? Because sometimes family members will also be struggling to get them back into community so that they can be enabling them to be more independent. Madam Lily, I think you're muted.
Okay. Yeah.
Thank you.
Yeah. Okay. The question. In my mom's case, hang on a minute. In my mom's case, she took a sleeping pill on a regular basis, which is something that we try to wean her off, but it's not easy. Now, I think to add to the reason why she couldn't sleep well, I suspect, although she didn't share with us, that a lot of elderly people, they think about their impending end of life. So they worry about whether they've got everything in place, and what happens. I mean, all this comes together in the mind, and it just bothers them. And also, this it depends on the family unit. If the family dynamics is not good, negative, then of course the older person will think of all kinds of things that make her feel so responsible, being a burden to the family. So there's a lot of things going on in their mind, and they can't sleep. The other thing also, which you mentioned about being isolated and depressed, that one, to me, can be easily solved if, there's a big if actually, if the elderly himself or herself will, take the first move to mingle, to go out. Now, that's why I always encourage senior citizens, you have to find buddies. You have to set up a buddy system. It doesn't have to be a lot. Just maybe 2 or 3. That's good enough. Whether it's from your neighbors, the nearest, even better, right? They'll be there for you. And if you need to go out, there's someone to drive you out to attend any functions, any meetings. So that's what I mean by bringing the kampong spirit back into our neighborhood. Many of us live in the cities, for example. We live in condos. We live in, even neighborhood. They all have their own communities, like the Ruku Tangga. And WhatsApp is great. WhatsApp is great for older people. They take to it like, I don't know what you take fish to water, right? They love it. They cannot do without it. So they can keep in touch with one another. And I always encourage management, of residential areas, condos, and so on. You step up. The management can step up instead of just taking only looking after the premises, the common premises, and collecting sinking fund and all that monthly thing. Why not you go further? Organize, social activities for all the residents on a regular basis, because that's the way. Community garden is a good one too, because in my desa, there's a community garden. They get together, right? They talk, they chat, they laugh, they help one another. This is something I hope to see happen in neighborhoods. That
Actually,
will
Kejal, if I can share, I think the kampung spirit is something very nice. Even in Singapore, the spirit of living as a kampung is something that is commonly spoken about. And in Singapore, I must say that we have so many elderly care facilities. There are aqua aerobics going on for the elderly folks. There's gardening, there are painting classes. There are so many facilities. As you know, in Singapore, the aging population on the rise. And to combat this, there are many such initiatives taking place. And I truly agree with what Lily has mentioned. This kampong spirit is something that is very, very significant and beneficial in hampering the negative calamities which are affecting the elderly folks. So this is a spirit which is very positive.
Yeah, no, indeed. Thank you, Dr. Hitin, for sharing the Singapore experience. Even in Malaysia, we do have a lot of these pockets of places where people can go. But I think it's also up to us as a family member and as community to support this, to grow this further. And rather than thinking, oh, they're safe at home, I can go to work and they're just there sitting at home. But I think it's the social participation that we are missing, which is going to be the key to really helping them to age more meaningfully and gracefully. And I think these are the values that we want to imbibe in us, even as we are trying to embrace aging. Aging doesn't happen after 60. It's a life course journey. And so we need to start it even from young. So thank you very much, panelists. I'm now going to swing over to the next
Dr. Kejal,
scenario. Yes?
could I just address one of the questions that came up in the poll that I
Sure.
wanted to be sure is I think sometimes we do think that if we're not sleeping at night, we should take a very long nap during the day. And while I think most of us as we get older will need short naps during the day, one of the problems with a very long nap is that it starts to, again, adjust your brain's expectations for sleep at night. And so one of the things we struggle with is that for people who sleep well during the day, they get worse and worse sleep at night. So one of the ways to intervene is to make sure that the naps are short, maybe 30 minutes or less, and to make sure people have exposure to sunlight first thing in the morning. Because I do think there's a sense, at least in my patients and my families, that, well, if they can't sleep at night, we should let them sleep during the day, but it perpetuates the problem. So that would just be one more thing to adjust in the environment, is to really allow daytime naps, but limit them. And again, to do the other environmental changes before sleep earlier in the evening to decrease stimulation and get them prepared. So thank you for letting me interrupt. I just want to, that's such a common thing I see in my practice, is that people start sleeping all day long and it makes the whole problem worse. So
yeah, no, thank you. I think you have summed case number 2 so well, that all we really need to build is a good routine, and the daytime sleeping should be avoided as much as possible so that you can get back to the circadian rhythm. Now let's move on to our next case. Basically, Mrs. Rajam. She's a 74-year-old lady with diabetes, high blood pressure. Over 6 months, her family has now started noticing that she's eating less. She's not wanting to really go out. She's mostly taking tea, biscuits, porridge, very few spoons of rice. She avoids eating meat because it's difficult for her to chew. And she's starting to lose weight, her clothes becoming loose. She's struggling to even get up from the chair and has also fallen twice while walking just to the toilet at night. Her daughter wonders whether this is just part of old age or is she grieving. And her family now restricts her diet because, remember, I told you she's diabetic, she's hypertensive. So no sugar, no high salt diet, and everything needs to be restricted because then she's going to get kidney problems. And the question is here, as you can see in the slide here, the family perception, we mean well, of course. But really, when we are meaning well, I think the clinical reality that happens at the back is something that we are missing the whole bigger picture. Refusal to go out can actually mean silently that they're getting into social withdrawal, into isolation, into loneliness, which will then be the trigger for subsequent spiral down events. So now let's launch the poll and understand a little bit more about Mrs. Rajam. So in the case of Mrs. Rajam, she's eating less, losing weight, becoming weaker, and has fallen twice. What should I worry about as family? This is part of normal aging, eating less. She may be developing frailty and muscle loss. I need to see if there's cancer brewing and causing all of this. She should rest more or avoid more falls. So this is quite a nice mix. About 70% are saying that she may be developing frailty and muscle loss. And I think we use the term frailty very loosely, and we will get Prof. Joseph to tell us a little bit more about this. But we also have someone who is saying that I need to see if there's cancer brewing because loss of weight is a red flag sign and I need to do all the CT scans and tumor markers to see whether mom is having cancer. Or someone is also saying that, losing weight, eating less is just part of normal aging. Thank you so much for sharing your insights on the poll. And now I'm going to swing back to Prof. Joseph. So, Prof, is losing weight and eating less really part of normal aging? And we use the term frailty in our poll. Would you be able to advise what really is frailty?
Yeah, frailty is an excellent sort of clinical term that we've evolved to understand over the past maybe 2 decades. It's where the body's ability to maintain strength disappears. This is a combination of the nerves and the muscles and the ability of the body to withstand sort of the normal stress that happens in day-to-day life, whether it's an infection or a loss of balance. When the body is frail, it isn't able to compensate and produce a nice, what we call homeostasis, or ability to withstand the challenges that the life faces. What we usually see in patients with frailty is both a loss of the amount of muscle that they have and the amount of bone they have, and also the strength of that connection between the nerves and the muscle to do things well. And I think a lot of us see people when they get very advanced frailty, they tend to get smaller, they tend to get slower, and they tend to get tired more easily. While some of this, there's always a small degree of this that's inevitable and part of aging, things that are changing quickly are often worrisome signs that there's another cause for that that hopefully can be repaired. So if someone is losing weight very rapidly, the most important thing is to work with a physician to figure out, is this something that is related to they're not eating enough? Is this from a medication that they're taking? Is this from a hormonal disorder that's causing that? And occasionally we do look for more serious problems like cancer. But often the frailty develops without a cancer. It's from some of the other things that we're doing. I do think anytime we are worried about weight loss, we worry about nutrition. And this is a common challenge as we get older. We probably don't eat as much in one sitting. We eat smaller quantities. It's a little bit harder to chew. Our stomach gets full faster. And so one thing we can really do to help our loved ones is to look at the whole day as an opportunity for nutrition and to provide easy to eat, easy to swallow, healthy things that have a lot of protein and in a small package, so that you can sort of achieve what your body needs to maintain its strength through easier, smaller meals throughout the day. This may be different than the rest of the family life, where we go many hours without eating and we eat a big meal in one setting. That strategy doesn't work as well as we get older. And so providing some easily accessible nutrition, particularly high quality nutrition with a small amount containing lots of protein and some calories, is really helpful. The last thing I'll say, Dr. Kajal, I do think sometimes we as the medical doctors interfere with this process. I think we get very worried about diseases like diabetes and high cholesterol. And it's for good reason. I think when we're younger and robust and eating too much, frankly, it's important for us to control those diseases. But as you get older, this over control of these diseases ends up being sort of a problem. And we want patients to eat anything they want. The most important thing is calories and taste. And because they're not eating large quantities anymore, it's okay to have food that used to not be recommended for them in the past because they had diabetes. It's okay to have food with some fat or some sugar in it if that's the food that helps you eat and get your nutrition. So I think it's very important to work with a physician who understands that the goals and the interventions are different as you get older, so that you're not trying to adjust the blood sugar too much and trying to prevent them from eating foods that would help prevent this frailty and muscle loss over time.
I love that you brought up the point about, it's okay to eat sweet food and those fatty food, because I think as family members, we need to understand that the targets are very different in older people as we become more frail, and it doesn't need to be the one size fits all for sugar control. Dr. Hitendra, like Madam, in this case, she started walking less, eating less, and she also had really bad knee pain. You probably see this knee pain in older persons very commonly. Now, how do we address and approach these people? And because many a times they don't even want to talk about surgeries. How do we address their pain, and how do you move forward?
Right. So we must understand most of the time the knee pain is due to a very common prevalent underlying condition called knee osteoarthritis. I'm sure most of you would have heard of this, and many people are actually suffering from this problem. And of course, if it's in a very, very severe stage, at times the only way out is to do a surgery, a knee replacement. But most of the time, you can actually mitigate the pain by actively, taking several measures. Not only when you are, reaching the elderly age, but even from a young age, you can start preventing degenerative changes. First and foremost, I think weight reduction becomes very important, because if you lose weight, the amount of load on the knee becomes less, and hence the pain becomes less. Because you must understand that degeneration is an irreversible problem. And if you have degeneration, you're bound to have pain. So the question now here is how to reduce pain. So if you reduce weight, pain becomes less. If you change the kind of activities you do, if you start running, jogging, of course it's going to be very painful. But if you start doing walks in the water as a form of exercise, then you are also rehabilitating the muscles. You're gaining more strength. You're burning calories. By the same time, they're not causing much pain to the knee. And of course, other supportive measures like wearing a knee brace, sometimes you may have to use a walking stick. These are all measures to help you ease the pain and yet be involved with the community and be active. So that is a very, very important understanding that we must have as an individual, so that you don't curtail yourself from activities, but you mitigate the pain. Sometimes trying to sit on the floor causes a lot of problem, but we can sit on the chair. So basically, it's a new norm, it's a new way of life. There are many other options how we can at least reduce the pain which limits our mobility. So I think that's a very important understanding that not only the individual should have, but the family should have collectively, to make it easier and better for the individual to be mobile in a more pain-free manner.
And is it okay to be taking painkillers if I've got knee pain? Is it all right for me to be taking painkillers?
Well, I think if you have to take it periodically, it's fine, but you should not be dependent on the painkillers, because most of the painkillers has many other negative effects on the kidney, on the liver, on the stomach. So many of my patients who are very heavily dependent on painkillers, then I will tell them that maybe you ought to think of a surgical option. But if you can live a life without being dependent on painkillers, but sometimes you have to be dependent on the mindset of changing a lifestyle, the mindset of having a new norm, trying to change your lifestyle in a way where you have to be probably less active, in the sense where you don't put too much pressure on your knee. That is sometimes very, very rewarding to patients. And with time, they can actually have a better lifestyle with less pain. So painkillers, I think, should only be reserved, in acute states where you really need to take them, but you should never be dependent on painkiller and continue living in the way you want to do things. And just to mitigate the pain, you keep taking painkillers. So that should not be the way. You should
Right.
avoid that
Thank
way
you.
of managing pain.
Dr. Surina, I thought this case nicely illustrated what you mentioned about, older person don't come to you saying I'm sad. They just start eating less, not doing much. So do you think Mrs. Rajam is depressed? And if she is, do you think it's okay to be on antidepressants? Because in our culture, it's almost a taboo to be seeing a psychiatrist and, to be starting on medication, because then I'm going to be dependent on it. If I stop it, then, it's not good. It's going to come back. What have you got to say?
Okay, thank you for Dr. Gija for this question, because before I go into about the depressions in with regards of this case, we can see that some people may think that it's just a normal grief because she just lost her husband and then start deteriorating slowly. Because some of us may perceive this is just a normal grief, just give time to her to recover. But however, how to appreciate this situation is either that this is grief or already depression or depression already set in. So grief can be the duration of grief normally can go up to 6 months. Sometimes it's a bit complicated one can be up to 12 months. But however, in grief, the sadness come and go. It's not like persistent. And sometimes over the time, they can slowly, the sadness can improve slowly, and they always can, appetite and the function can gradually improve over time. However, when the depression started set in, over the time, the low mood is still persistent. They're not able to enjoy the activity. They start withdrawal from the relative and the activity outside, and definitely they start affecting appetite, weight loss particularly in this situation. Because in other way, for us to see that the depression in elderly, I like to cluster the symptom into three main cluster: mood symptom cluster, biological symptom cluster, and cognitive symptom cluster. So usually in elderly, mood symptom, they're not always presented to us with the mood symptom. They always presented to us like biological symptom, loss of appetite, loss of weight, sleep affected, and also some cognitive symptom. For example, that they complain of like, I'm burden to the family, feeling hopeless and worthless. So this is sometimes a way for us to differentiate this is already depression or just a normal grief. So with regards of medication, yes, if the treating doctor, I will definitely, I think these patients already have the depression, because we can see that over last 6 months, she's deteriorate. So weight loss, significant, poor eating, no longer involved with the social activity, and physically declining. So my suggestion for the family, usually we should treat the depressions, and antidepressant is basically safer for all the adult, and if we have a variety of medication that usually that suit for them. And antidepressant is not that something that's sedative. Like we always think that once we're on a medication, that's it. We need to be on a medication like forever. But actually not. The earlier we treat the depression, the earlier they recover, and there are chance for us to tapering off the medication, and eventually they can off the medication. So usually this is the important point that we need to highlight the family, because I know that is a struggle for us. In Asia, I think we encounter this a lot, when you try to tell the family, this is depression, but sometimes they don't feel that it's depression, because they think that it's possible of cancerous activity here, because already weight loss and poor appetite. So they want to wait further, because and another reason, they're afraid that by giving medication, they will have more side effect, they will not recover from the depression. So there's a lot of education to the family to correct the perceptions on the medications, particularly antidepressants for the family.
Okay. And so I guess it's not just the pill, it's also the social support that they get. And it's back to Madam Lily in terms of the kampong, the vibe that people bring. So if we are as at the neighborhood, I guess if we would have been able to pick up that, she's going down, her mood is getting lower, and, she's not engaging as much as she could before this, then as a society, what is it can we do? Because the pill alone may not solve all the issues. She still needs to get back into social participation. And that's what the psychiatrist will usually, even offer psychotherapy. So what can we do as a society, Madam Lily?
To me, because of my background, I still think that, one of the best solutions is social connections, because it keeps you busy, so you sleep well, and you're not so isolated, you're not depressed, and there's always somebody around to chat with you, or it's one whole, like I would say, a big answer to a lot of problems for older people. In my mother's case, she had no problem with appetite. In fact, she has a huge appetite. She'd be even, in her state of mind, she would even look at the next table during a Chinese New Year dinner, and she would go over there and take their food as well, which is a little bit awkward for us sometimes, But yeah, the point is this, that if the elderly is kept busy in various ways, activities, there is very little chance of them getting, depressed, because they're occupied. And, mentally, you take up, I always advocate learning, take up a course, right? Whether it is in music, learn a new skill. And the University of the Third Age has over 50 short courses to offer in all kinds of categories, whether it is herbal gardening, music, languages, art and craft, is all there. So I highly encourage adult children to recommend that their parents sign up for some of these courses.
Yeah, no, I totally agree. Thank you so much. I think you summed it up so well that I think the biggest void that we are facing in this whole process of aging gracefully is maybe the lack of social participation and our awareness on the importance of all of this. Thank you so much, dear panelists. So we have got the last few minutes left, and I just wanted to go through some of the questions. So to all our audience who are tuning in, thank you for pouring in lots of questions. We have about 100 over questions that have come in. We'll try our best. If we will definitely not be able to address all here. We'll collate the answers from our experts and we will share it with you so that you do get answers to your questions. But maybe I'll just pick a few because some of it has already been answered along the way through the panel discussion. So I think the one question is, how do we cope as aging adults ourselves when we are having to care for our elderly parents and our children? In other words, the sandwich generation, when you have an older parent to care for and you have got children to care for. Maybe Prof. Joseph, would you like to take this question?
Yeah, I would, and this is really hard across, I think, our society as well too, and some of this will need our governments and our communities to sort of participate and help us sort of manage these things. I do think the most important thing is to try to find, you don't have to be perfect. You just need to try to do things that align better with what you need. And I think involving older adults in family life and making sure they're not shut out of this because we're worried they're going to fall, or that they should sort of sit and be quiet while we're doing the rest of our work is really helpful. We want them to feel useful. A lot of physical activity can be built into normal family life if they accompany you while you're doing things with the children. Even if they don't walk the full distance, they can walk part of the distance and sit and wait for the rest of the soccer game or whatever to finish. I think as people in the generation responsible for lots of the family staying together, I think there's ways to find things that sort of satisfy both of your obligations to your children and to your older adults. I think another thing we commonly recommend is, how can we make food preparation and meal times? I have to do it anyway. I have to do it for the kids. Is there a way that my mother and my father can help me? Maybe not in the exact same way they did before, but in some way that's socially engaging for them, that involves some physical activity. So try to find a few things that are useful for all of your obligations, and unify them into something that meets these goals of more mobility, more social engagement, more meaning, and getting them to bed on time.
Right. Thank you.
May I add something with because this sandwich generation is very big things. And from the psychiatry perspective, sometimes I usually tell my caregiver, because they are in between parent and their children, right? So I always tell them, it's okay if you think that you cannot cope. It's okay to say that I need help, because sometimes when we are in the middle, we feel guilty to say that I'm tired, that I need rest, because I need to take care. This is my obligation to take care of my children and to take care of our parents. So because of our culture to not allow us to openly say that we are tired and need help. So I usually reassure them, it's okay to say that I'm tired, that I need help, so that you can find the support surrounding and to help whatever that the things that you need.
Right. I think it's so important to acknowledge that it's okay to get help, and there's so much of help out there that's available. It's just for us to look for the right resources to be assisting us, so we ourselves will have a better quality of life. Now, there are a lot of other questions as well around dementia, and since it's you, Dr. Serena, I thought I'll touch it with you. Are there some advances or anything new in the care of dementia that's happening currently?
This is tough, tough questions. Yeah, the new things care in the dementia here. I think it depends to the area of the patients and the caregiver, because I think that is a quite significant for us the area they live, because there are quite significant discrepancy between the rural and the urban area. So the accessible of the care is quite limited for some people in the rural compared and someone in the urban area. But somehow now, because we have that online helps for the caregiver, so that sometimes the online resources also can help for the caregiver to get the supports and also the tips how to care of the family and to get resources, how to get help for the family and for themselves. So that's my input on this lah.
Dr. Hitendra, would you know, are there some resources in Singapore, in this region, that can help people who are caring for people with dementia? Because it can be quite daunting to be in the journey, to be caring for these older people.
Yeah, definitely. There's a lot of support groups here, both governmental and also non-governmental. And then some of the, religious bodies also contribute in, looking after their different group of community members through various activities. So certainly in issues like dementia, and many other issues, there are a lot of support which is available. And one example I would give you is we have this thing called a mobile clinic. It's not a mobile clinic where they treat hypertension or diabetes. It's basically your mobile clinic where they actually try to teach elderly folks how to accustom themselves to the use of use of the handphones, how to use WhatsApp. So this is what the social integration becomes very important, and I think such things makes the mind active, and you will be less vulnerable to conditions like dementia, depression. So the key thing, like what Lily had earlier mentioned, it's social integration, and this I think is something we should all try to actively, think of and try to incorporate in our society in whichever way we can.
Yeah, certainly. So I think if we're talking about the care of dementia, one is preventive. How do we not get dementia? And if you're already in, how do you then help yourself so that you don't progress further? And majority of the things are non-pharmacology. The pills that you pop in are really not magical boosters to help us with our memory. I thought it's nice to end our Q&A session with one last question, which is probably going to be first to you, Madam Lily. Someone has asked this question: assuming I've achieved financial independence, what should then be the ideal age for me to retire? And I think my biggest question is, should one retire at all?
If I had my way, if I were the PM, I would say do away with retirement age. Let people, work as long as they are able or fit enough, right? And I think that should be the way to go, because there's a lot of changes. If you look at my mom's generation and compared to our baby boomer generation, I'm 78. I think there's still a lot of life in me, right? I can still work, Yeah. So, but what I want to say as the last few words here, I want to go back to foundation. Everything has to do with foundation. We are talking about this mostly in a reactive sense, but let's be a bit more proactive. Both can exist at the same time, right? We can show by example to our grandchildren, for example, how we look after our elderly. They will learn from us. They can give us a hand. In fact, when my mother had dementia, right, my grandchildren help with looking after her so that I can get some respite, some rest. So it takes the whole family and also the whole neighborhood, yes, to help one another out. This is how I see going forward.
Very nicely put. And I think it's these values that we have to bring in from young, and it doesn't just happen overnight. So we will have to start leading by examples to our children and imbibing all these values of love, filial piety, righteousness, and even honesty. Because it's only these values which will then carry on with us, and we'll be able to face the challenges that we are faced with as life, unfolds itself. Sorry, yes.
May I just
Sure.
add one more?
Sure.
And I forgot about that earlier. I think one way to keep elderly at home from being isolated and feeling lonely is to give them a purpose, right? A purpose. For example, volunteerism. If they can't go out, they can do something at home to contribute, making things, right, for the church or for the community, and then selling it. Or even giving tuition. Giving tuition at home, they can earn some pocket money as well. And the neighbors' children, you don't have to drive your children all the way somewhere else. Within your own community, there's a retired English teacher, retired maths teacher. Just bring your children over to next door neighbor. So these are the things that I keep going back to, because I firmly believe in bringing back the kampong spirit to help one another.
Thank you. Thank you very much. I think all the answers that the panelists you have given they're very practical. They are very relatable to all of us, and I really thank you all for that.
Dr.
Now,
Kejel,
yes?
Dr. Kejel, sorry. Before you do the next part of today's session, I would like you to invite everyone to look on to the chat group. There is an invite to join our community for this special health program set up by the Institute, so that if they click on that link, they will join the community where they can be in touch with the speakers and the experts to get the relevant information and some guidance, or we can point them to the right place for information.
Definitely. Thank you. Can we just have that slide for the QR, and we will repost the link in the chat group, so you can join our community chat to get more updates and also some important resources that we had discussed in our panel discussion today. And with this, we will close the Q&A session, but I totally understand that there are lots more questions. So sorry, this is basically the QR code. If you're able to scan the QR code, do join us in the WhatsApp, but otherwise in the chat group, the link is also available for you to join in. So you get to keep yourself updated and also see what's next in store after joining this first ever webinar. So at this point, I'd like to now warmly invite Professor Dr. Suresh Govind, the advisor for the Asia Pacific Sathya Institute for Human Values Education, to share a few words. Prof. Suresh has played such an important role in shaping the birth of this A.G.E initiative and is helping us to see it as more than a one-off webinar. Being a visionary himself, his aim is to create an ongoing space where families, older adults, professional, and communities can come together. Prof. Suresh, the floor is yours.
So, distinguished guests, ladies and gentlemen, really speaking, this has been the last 90 minutes of incredible, seamless flow of energy and information. That is really, if we really act on some of this information, in fact, today I really feel inspired because there are so many ideas that came from the experts. What is the objective of the Asia Pacific Institute? We want to be really the bridge between the experts who have got all this knowledge and the common man. We want to bring the knowledge everywhere. You see, if you go to any parts of Africa or Europe or America, if there's a red light in the traffic light, you stop. Red light does not mean anything different in any other country. It just means stop. Green light means go. So that knowledge becomes pervasive. It is empowered within us to know what to do, how to do, and why we should do it, you see. So the whole point is that the aging population is becoming more and more aging. There is going to be more and more of it. We need more and more volunteers. And I like what Dr. Lily said. It's actually really, that is the whole nail. Because we need to increase more and more younger people, more and more people who are in the family itself to become empowered to see, hey, that is dementia, hey, something is not right. You see, we need to make people become aware what is right and what is wrong. What is to send? How do we sensitize them? That is what we should be doing. And basically, if we can sense there is something not right, I need to go to the experts and get my elderly grandfather and grandmother, bring them out and connect that. Then I think we can solve a lot of problems, because as the statistics show, after the first fall, the second second fall will become more risky. Things are going to become more and more problematic. And the whole idea of why this particular seminar is so beautiful and wonderful is because it is an expression of love. You see, unless we say we love our grandmother, we love our father, we love our mother. But what is that concept of love if we just come to only a certain point and we cannot empathetically feel the pain? If the father or mother, grandmother, grandfather fell, that hurt would be experienced. We can come up to the bed, but they go through that pain. And it's really painful to see them go through, and also painful to see the family members go through. It's really compromised the quality of life, both in the people who are suffering as well as the family members. And it can be really mitigated if we become aware. So you see, the subject matter is about loving. Subject matter is about creating a caring community. Subject matter is about humanizing people to make them feel connected. And that is one of the major objectives of this Asia Pacific Sathya Institute, to bring to humanize people and to connect to them and make people feel for one another. Third point is that the concept of this kampong thing is such a beautiful. Dr. Hitendra mentioned that. Kejal mentioned that. And really, I think one of the take-home points really is that we need to empower non-governmental organizations, NGO, voluntary organizations, to create community gardens within the resident association. We don't need to go too far. Even where they are staying, if we can create community gardens, bring elderly people of various races, and this again promotes national unity. We bring many people together and instill this kind of small little things that can make the mind active in itself. That itself is very big, very, very big service that we need to do. Actually, the whole idea is the mind. If the mind is active and the mind has got something, a higher purpose, you got no more problem. The moment the mind loses the spirit, and even the best medical care you have, if the mind loses the connectivity to something higher, we lost the hope. So to keep the mind active, we need more and more young volunteers. We need more and more voluntaries. The spirit of voluntarism must really go to a very high height. And I think Ganesh's, Associate Professor Dr. Ganesh's, the community that is being created, if you all can connect to that. And after this, there's going to be a modular program for five other subjects that I'm sure Dr. Hiten will explain. The 5 other subjects that if you register, and I think you should register, they become more empowered to understand in detail what to do, how to do, and when to do those interventions, which will be useful. This again is not a substitute. That means to say you are not a medical doctor, we can't intervene, but at least you can become aware. That awareness itself will raise a level of care and compassion in our communities. And I think this is something so wonderful and so beautiful. It should become more and more. Next time, there should be 500,000 of our people should be participating. We should get more and more other communities also involved. And this should spread like a wildfire. Everywhere, everyone should become very, very concerned that our elderly people, our elders, because don't forget, we also are becoming elderly. we are also becoming senior. So if we create a good environment, that environment will look after us as well. Well, it's not for a selfish purpose, but really speaking, that's how we should pass from one generation to another generation. And if we had this conference only for the medical people, you know what will happen? All the medical experts will go to that conference and they'll see the posters, they'll have the deliberations and all that. The common people will not get this. So this is why we need to bridge this nicely and beautifully. And the fact that all of you, Dr. Joseph, every one of you, from so many wee hours in the morning, you're willing to come and sacrifice the time. That sacrifice that you have done for this particular session, I'm telling you, it's amazing. It's an incredible gift that you have given us. I hope the Asia Pacific will really grab this opportunity and make this a very incredible intrinsic lifestyle culture change, which we must bring to humanity at large. Thank you so much for this opportunity. Thank you, distinguished speakers, for making this evening such a memorable one. Thank you. Thank you.
Thank you very much, Prof. Suresh. I think you have ended it with such an inspiring note. And we do look forward to having everyone in for the subsequent 5 modules that are coming up. So we can then empower ourselves, because we are, like you rightly said, we are also aging ourselves. So before we end, if we could just request you to fill up the feedback forms. The QR code is on the screen. And We have also put in the link in the chat group. Please do provide us your feedbacks because it will only help us to improve, and we also hope to address the needs that are really needed for us to get better together. So I think with this, we have come to an end, and I think the bigger message for today is really, aging well is just not the problem or the responsibility of the older person alone. It is a shared responsibility between individuals, family, healthcare professionals, communities, and societies. We hope that this session has given you enough of information, but not just the information, but also the confidence, the direction, and hope that, there's so much out there to be able to help us to age gracefully and effectively. Please stay connected with us through the WhatsApp community group, and we look forward to having you all in the upcoming modules. Let us all take the step forward to A.G.E, Aging Gracefully and Effectively. With that, thank you all very, very much. Have a lovely evening and weekend ahead.
Thank you, everyone.
Thank
you,
you.
speakers.
Thank you. Nice to meet you all.
Yeah, thank you.
Thank you very much, dear panelists.
Thank you.
This is a very nice session. Wonderful. Thank you for inviting me.
Thank you,
Dr. Kim
speakers.
John,
You've been
Dr.
wonderful. Thank you so much.
Thanks.